Now I am very happy. Today we have 56 online viewers sitting in the home. That should be the thrill of the modern e-learning. Even when you are on a night duty in the hospital, simply if you have a data card which has a good speed, if you are closer to the 3G server, you can be able to participate in a live conference and be able to participate in the discussion. That is all the future of learning, no need of traveling and wasting time. So for your juniors, we wanted to say that from January 7th onwards, we will be starting every day live interactive session, evening 5 to 8 p.m. 1 hour of session, then 15 minutes quiz, then there's a discussion on the quiz where you will participate actively, then another 1 hour we discuss, and then after that there is a quiz. So every day we will have a session, Monday to Fridays, and Saturday we have a subject test and discussion as usual, and Sunday full length need pattern test and discussion. Like that in 30 weeks, starting from January 7th till August last week. So that November, once more next year, it takes no time, once more the NEET exam to come up. So, but the advantage is, if you miss it, you always have the recorded video available in the video library of that day's session. But always there is a joy in proactively participating in a live session. Now doctor, BRCA1 and BRCA2 mutations typically can be associated with ovarian cancer. It is a transvaginal ultrasound screening which is considered to be a wonderful strategy to reduce the risk. Now malabsorption, iron deficiency, if it is there, think of celiac disease, and in them you need to do anti-endomysial antibodies which will be typically positive. Now tell me doctor, very good valid question from Warangal, do you want to do direct oophorectomy if there is a family history and a positive lesion on screening? A very good question to all. Dr. Anuja says for the earlier question, why not D? In the end we will take up, doctor. You mentioned question number, what is your alternative answer? We will raise a debate on that at the end of the session. And just hold the number of, probably we may be wrong some places, and when so many online communities there is no chance of our going wrong. You can always correct the key then and there. Now coming to chloride H plus CO2 2,3 dBg and temperature, any of them if they increase, what will happen to hemoglobin? Will T become R or R form will convert into T? Dr. Vidya says T become R. Dr. Siri also says T over R. Everybody say T over R. That's right. So remember, doctor, T is taut. When hemoglobin is taut, it has a low affinity for oxygen. When the hemoglobin is R, relaxed, it has more affinity for oxygen. So doctor, if there is an acidosis or whenever there is hypercarbia, in all these scenarios, a taut form where hemoglobin has a very low affinity for oxygen is a preferred form over that of the R form. Fetal hemoglobin may what form will be there? R form, because it has got a very high affinity for oxygen. You can remember, when you are relaxed, you do your job better to carry oxygen. So your affinity for oxygen will be higher. So that's what need to be remembered. Minimal change glomerulopathy can be a complication of interstitial nephritis, Hodgkin's, HIV, any of them basically. Idiopathic is most common, but there can be secondary causes like drugs. rifampicin, interferon, ampicillin, penicillin, trimethadione, they are all secondary causes. Toxins like mercury, lithium, bee sting, infections like HIV, tumors like Hodgkin, any of them can lead to development of minimal change disease is what need to be remembered. Now multicentric lymphadenopathy. What is the difference between Hodgkin's and non-Hodgkin's? In Hodgkin's, it is often more localized into one axial group of nodes like cervical. More multiple peripheral nodes is non-Hodgkin. Contiguous is Hodgkin. Mesenteric nodes and Valdier rings are more often involved in non-Hodgkin. Extranodal visceral involvement is more common in the non-Hodgkin, is what you are going to ultimately remember. So this is how there can be a mediastinal lymphadenopathy in the form of an anterior mediastinal tumor, can be one of the presentations of a terrible lymphoma can present. What are the 4 T's you will remember in relation to the anterior mediastinal mass, doctor? T for teratoma, T for thymoma, T for terrible lymphoma, T for retrosternal thyroid is what you are going to ultimately remember. Now doctor, AIML in this gum hyperplasia bleeding visceral infiltration, in which entity do you see? Monocytic form. Today only mark it as my word, doctor. ALL, AML, CML, CLL, Hodgkin's, non-Hodgkin's, lymphoma, and hairy cell leukemia, and mantle and maltoma. One question definitely going to come, whether your morning session, evening session, out of the 14 days battle of the NEET PG, Bharat Sangram, you must be like the Yodha Arjun, you must be ready to get ready and fight with all ammunition chiseled in the next 40 days to come, without the fear for the battle. That should be the spirit, doctor. Now this kind of colored red, purple plot type of lesions on the scalp can be sometimes the presenting feature of the monocytic form, and there can be a monocytic infiltration of the dermis. Mononuclear cells can be CD45-20 positive, and this kind of periorbital lesions are also very common, is what need to be remembered. What is red cell distribution width is an important question. What is the red cell distribution width ka kaam kya hai? What is it a measure of? It is a measure of, you remember Amitabh Bachchan's song, जिसकी बीबी मोटी उसका भी बड़ा नाम है, जिसकी बीबी लंबी उसका भी बड़ा नाम है. So some cells are mota, some cells are lamba, some cells are thin. If there is a poikilocytosis, there must be some statistical way of measuring the degree of variation in the shape of RBCs. Why will poikilocytosis occur? Basically, if there is anemia and the bone marrow is trying to compensate for that anemia, when it is overproducing the RBCs, it will produce, instead of a uniform shape, multiple shapes. RDW is an important indicator of that variation in the volume of the RBC. Typically, iron deficiency or thalassemias are known to lead to poikilocytosis and hence an increased RDW. But megaloblastic anemia does not lead to a change in the volume, is what need to be fundamentally remembered. Now coming to the prion proteins, prion versus normal condition, what is the main difference? Prion causes spongiform changes, infectious, transmissible, but unlike viruses, bacteria, it does not elicit inflammation, is what you have to basically remember.